Chapter 42, Lower GI Problems. Okay, we're starting off with diarrhea, infectious and non-infectious. The next several slides, again, are self-study, so please read about them in your textbook. So I'm just going to hit a few little points here. So definition of diarrhea is 3 or more loose stools per day. Infectious is the most common reason for diarrhea, so if you have a patient that has diarrhea, always protect yourself with the appropriate PPE. Okay, so you can go through this on your own, read about the different diagnostic studies, different things that we look at. Diarrhea management, we have medications that can help stop the diarrhea. One thing I want to mention is if it is infectious, we don't want them to stop pooping. We don't want to stop having a bowel movement, because if we give medications to get rid of the pathogen bacteria, we want them to poop it out of their body. So just be aware that if it is infectious, they really shouldn't be given antidiarrheals. Okay, again, we're losing bodily fluid through diarrhea, so we want to monitor electrolytes, monitor fluid balance, nutrition. We want to protect the skin. That can lead to skin breakdown. And then diarrhea for anyone, whether it's a walkie-talkie patient or a bed-bound patient, it puts them at high risk for fall. So we want to make sure we take that into consideration. Hand washing, infection control precautions. We want to make sure we wash our hands when it's C. diff, okay? Using hand sanitizer will not get the C. diff off your hands. Make sure you wash with soap and water. Okay, fecal incontinence, read about that in your textbook, please. Okay, assessing the stool, assessing bowel patterns. So of course, if you have a patient with diarrhea and you're told this on report, then a question you should ask is, how many times did they have a bowel movement? What is the consistency? Has a stool sample been sent to the lab? Is the doctor aware? How's the skin looking? Those are all questions that you should ask when another nurse tells you their patient has diarrhea. Okay, more self-study. You can read up on bowel training program. If a patient is trying to get a regular schedule of bowels, the best time to eliminate is about 30 minutes after breakfast, because that first morning meal will cause peristalsis and hopefully trigger defecation. Constipation, which is the opposite of diarrhea. Lots of different reasons. Please read through this, page 929 in your textbook. These are all risk factors that contribute to constipation. Okay, again, please read through this. What you'll need to know for sure is how to manage constipation and how to prevent it. So these things listed here, again, please read more about them in your textbook. You want to increase dietary fiber, fluids, and exercise. That's really important. All of these things mentioned here, fiber, fluids, and exercise, does not need a doctor's prescription. So that would be the best thing to educate on. And then medication-wise, again, you want to know how to use those medications. Nutritional therapy, self-study, please go over that in your textbook. This is assessment and implementation. Again, this is directly from your textbook. All right, so our first lower GI problem, acute abdominal pain. So you can see in this picture, it kind of gives you an idea of what is in each section of the abdomen. And we're talking about acute, sudden onset of pain. So if one moment you're fine, the next moment you're not fine. So we take this seriously because it can often be something major. It can be bleeding, obstruction, peritonitis, and all of those things can lead to death. So this is not from your textbook, but I kind of liked the way it's set up here. So you can see if you have pain in this specific area, possible reasons that it could be. Okay, this one is from your textbook, and it shows how the origin of the pain can equal a life-threatening effect from that. So please review that. So signs and symptoms of acute abdominal pain is going to be pain, along with some other GI symptoms like nausea, vomiting, diarrhea, constipation, flatulence, fatigue, fever, possible rebound tenderness. That is when you push down on the abdomen and there's no pain, but then when you let go and the abdominal wall rebounds, that's when you have pain. And then also bloating. So diagnostic-wise, we want to get a good H&P to find out some clues of what happened. We're going to do a pain assessment. We're going to pay attention to what position makes them feel better. We can do an abdominal X-ray, ultrasound, CT scan to further look inside the abdominal cavity. We're going to do labs, possible urine analysis and pregnancy test if it's a woman to make sure she's not having an ectopic pregnancy. So our goal here is to find out what's wrong with it, to monitor and prevent further complications, which can ultimately end up in shock and death. Pain management. A lot of these times, these patients will need surgery. Nursing-wise, we're going to keep an eye on fluid and electrolytes, pain, anxiety, insert an NG tube, monitor for hypovolemic shock. So you will see that a lot of this is the same interventions over and over. So pre-op and post-op is going to be very typical for any other type of surgery. Okay, for this one, if they have an NG tube in post-operatively, we're going to monitor that drainage, make sure that we give antiemetics if necessary, monitor fluid and electrolytes, and promote early ambulation. If they are going home or if this was done on an outpatient basis, we want to make sure they follow doctor's orders related to activity, incision to prevent infection and what to report, the proper diet, and to follow their medication regimen. This is from your textbook. You can kind of read it over. This is emergency management of acute abdominal pain. Chronic abdominal pain. So this pain is not sharp and it's not specific. So it's dull, it's aching. You can't really pinpoint where the problem is. So common causes, and there's a lot of them, could be irritable bowel syndrome, chronic pancreatitis, hepatitis, PID, and so on. This one, we do want to get a good H&P. We want to get a good feel for when the pain happens, what makes it worse, what makes it better. I'm going to do some imaging studies and hopefully find out what's wrong. Abdominal trauma. So we have lots of important organs in our abdomen. Almost everything we need to live is in our abdomen. So we can have lacerations, ruptures of organs, tears, all kinds of stuff can happen, and that can be blunt or penetrating. So something blunt means there's no broken skin, it's just kind of blunt trauma. That could be from a car accident, a fall, and then penetrating examples could be maybe a stab, knife wound, or a gunshot. So our biggest concerns with abdominal trauma is shock because the patient can be bleeding internally. Peritonitis is when the peritoneal cavity around our organs fills up with either blood or the contents of an organ. And then these patients could be at risk for abdominal compartmental syndrome, which is when the pressure gets so high from all of that extra, whatever it is, fluid, that it starts pushing on tissues and organs and causing issues that way. So classic signs and symptoms of abdominal trauma are guarding and splinting the abdomen. The abdomen will become hard, distended, rigid. Bowel sounds will be very decreased or absent completely. If there is a hemorrhage in the abdominal cavity, that can manifest as Collins or Gray Turner sign. Abdominal pain, bloody vomit, blood in the urine, and then you're going to have those classic signs of hypovolemic shock if it is severe. These are examples of Gray Turner sign and Collins sign. So Gray Turner sign is this ecchymosis on the flank, either one flank or both flanks. Collins sign is periumbilical bruising. Okay, so we're going to get labs, we're going to get urine, we're going to check bleeding times. They'll probably need a type and cross match just in case they need a blood transfusion. We can do ultrasound, CT scans, peritoneal lavage. Peritoneal lavage is when they insert a catheter to drain out some of that fluid. That can be helpful in a couple ways. That can give them insight to what is actually in there. Is it blood? Is it fluid? Is it stool, brown colored fluid? We're going to give them IV fluid. They need IV access, NG tube, and if it's an impaled object, we don't remove it. Moving on to irritable bowel syndrome, or IBS. So this is chronic abdominal pain and alteration of bowel patterns. So alteration of bowel patterns could mean diarrhea or constipation, or it can go back and forth between the two. There is no specific cause for this. It's not a pinpoint diagnosis. It is often related to psychological stressors. So if somebody has a lot of anxiety or fear or any kind of emotion, it may be manifested by this irritable bowel syndrome. I gave the example in class of when you're really, really anxious or really, really nervous, and then you have diarrhea. So if you just have one episode like that, you don't have irritable bowel syndrome. But if every time you get anxious or every time, some type of emotion, you have diarrhea, then you might have irritable bowel syndrome. Okay, and then also we consider some dietary intolerances part of IBS. So some of those dietary intolerances include gluten, okay, and FODMAP. FODMAP refers to fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. So this chart here shows you what you should avoid and what is okay to eat regarding the FODMAP diet. This is how you get diagnosed with IBS. So this is based on symptoms, and most of it is subjective. They use the Rome 4 criteria, and IBS is categorized by the stool patterns via the Bristol stool forms here. So we get a good health history on the patient and the family, what medications they're taking. You can't be diagnosed with IBS if you're taking laxatives every day. Okay, so that kind of thing, is it medication that's causing it? And then you want to know how much it's impacting the patient's life, and that will also determine how aggressive the treatment will be. And then we also want to do lots of other diagnostic tests just to make sure it's not something else. So once they rule out other disorders and conditions and they can't really find anything, and then they still meet the criteria, that's when they'll be diagnosed with IBS. And then you can read this chart on your own, the criteria for IBS. It's just related to how much pain they have, how often, what their stool looks like, and how often they're having that type of stool. So signs and symptoms again, this is kind of just very general: abdominal pain, nausea, flatulence. These patients can have mucus in the stool, sensation of incomplete evacuation, so they've already had their bowel movement, but they feel like they still got to go. Non-GI symptoms can include fatigue, headache, and sleep problems. So for management, it really just depends on the person. There's no single effective therapy, but there might be psychological support. So if they're stressed out, then we want to, target what is causing the stress. If it is food related, then we want to encourage that FODMAP diet. And then we want to help kind of train their body to have appropriate stools. Okay, so that might mean incorporating some medications. Moving on to inflammatory disorders. We have appendicitis. This is inflammation of the appendix. This is the most common emergent abdominal surgery, commonly between the ages of 10 and 30. And this is when a fecalith obstructs the lumen of the appendix. So a fecalith is a hard, stony mass of feces. So you have some stool rolling around in your intestine. It doesn't make its way out as it should. Instead, it's just rolling around, getting hard, turns into this little stone, and it lodges itself in our appendix. Okay, once it goes in there, it can obstruct blood flow, it can cause inflammation, infection, necrosis, and that's when we start to feel pain. So initially, there's just going to be some dull pain. Maybe you don't feel hungry. You might have some nausea, vomiting. But then you're going to start having persistent pain in the right lower quadrant at McBurney's point. Fever can develop, definitely some localized tenderness to the touch. Rebound tenderness is kind of a hallmark with appendicitis. Pain when coughing, sneezing, breathing deep. If a patient has all of these things and all of a sudden they feel better momentarily, that's usually an indication that the appendix has ruptured, and that will be temporary. The pain will come back, but that's definitely something urgent. They should seek medical attention if they haven't already. If it's an older adult, they tend to have less pain, a lower fever, and their pain is actually felt in the right iliac fossa. We can do an ultrasound, MRI, or CT scan. The goal is to avoid rupture, so hopefully it hasn't ruptured yet and we can do surgery to remove it. If it's already ruptured, then this can quickly lead to peritonitis, so we want to get in there, wash out, do an abdominal washout, make sure the patient has adequate IV fluids and antibiotics. So this is McBurney's point. It is 1/3 of the way between the anterior superior iliac spine and the umbilicus. So if you see, this is umbilicus and this is the anterior iliac spine. It's that pretty hard bone you can feel usually when you're lying on your back. And then you draw a straight line. Okay, 1/3, 1/3. It's right here. All right. Okay, so the top picture is a very angry, inflamed appendix. And then the bottom picture, you can see it cut open. That is a fecalith. Perfectly round. All right. So how do we manage this? Again, preoperatively, they're going to have IV fluids and pain medications. We're going to, of course, try to prevent complications. They should be NPO, nothing to eat or drink. Monitor vital signs and give them some anti-nausea medication. Post-op is going to be very general. Hopefully they had this done laparoscopically. We want to promote early ambulation that gets things moving, and then advance their diet as tolerated. Definitely, if that appendix ruptured, they will have some IV antibiotics post-operatively. Now we're at peritonitis. So this is inflammation of the peritoneum. If you look here in our picture, the peritoneum is pretty large. It pretty much engulfs all of our abdominal organs. So usually a patient will develop peritonitis when they have a blood infection. Whatever organism is in the blood kind of makes its way here, and then it starts to infect the peritoneal cavity. Another way, the second most common way that you can develop peritonitis is when an organ is damaged and ruptures, and then it spills its contents in there. Most commonly, it's going to be the bowel or the stomach. So remember, when we eat, that is not sterile. It goes down. It's eventually turned into feces and stool. So if that material spills into our peritoneum, then that can quickly cause infection. So the most common sign and symptom is going to be abdominal pain. There can be tenderness over whatever area is involved, rebound tenderness, muscle rigidity and spasm, abdominal distension, fever, tachycardia, nausea, vomiting, altered bowel habits. So again, a lot of overlapping signs and symptoms. This can lead to shock, sepsis, abscess, paralytic ileus, and acute respiratory distress syndrome, and death. So this is urgent and needs to be recognized and treated. Diagnostics, we're going to do lab work, electrolytes. We can do peritoneal aspiration, so we can get a look of the color of whatever's coming out. It can also be tested for to see what organism is in there. Imaging, X-ray, ultrasound, CAT scan. We can do a peritoneoscopy, which is pictured here, where they go in with a scope to take a look at what's going on in there. Surgery, sometimes if they do not need surgery, they're just going to be NPO with an NG tube, IV fluids, antibiotics, pain meds, and antiemetics. If they do have surgery, it's actually going to be the same thing. So they're going to try to locate the source, what is causing it. So if it is an organ that is ruptured, they need to repair the organ, take out and drain all of that purulent fluid, and then do an abdominal washout. So post-operatively, again, NPO, IV fluid, NG tube to suction. They may need a blood transfusion. They need to rest the bowels, so they might have TPN temporarily. Antibiotics, possible sedatives, pain meds, antiemetics. So interventions, we need IV access. We're going to manage their pain. For peritonitis, if they have their knees flexed, that helps with pain relief. We want to monitor their vital signs, eyes and nose, oxygen, and so on. And these patients will most likely have a drain. So they will probably be discharged with a drain. So that's more education that you'll provide to the patient. Gastroenteritis. So this is very similar to gastritis, but this involves or includes the small intestine. So very generic. This is a short-term illness. It's usually self-limiting. You get like a bout of sudden diarrhea, nausea, vomiting, fever, maybe some cramping. And this can be from viruses, bacteria, bacterial toxins, parasites. Some medications can cause this. Most common foodborne cause is the norovirus. Again, this is self-limiting. We're just going to test for the virus or test the stool to see what bacteria is in there. We want to stay hydrated, and we're going to treat this similar to how we would treat diarrhea. Now we're at inflammatory bowel disease. So this is chronic. Okay, this is not acute. This is chronic inflammation of the GI tract, and this is going to include periods of remission and periods of exacerbation. So that means patients will be feeling good and then not so good for a while, and then they'll be feeling good, and they're just going to have these recurrent episodes like that for the rest of their life usually. Two types we're going to talk about is ulcerative colitis and Crohn's disease. So we're going to talk about the differences. Causes could be autoimmune, environmental, some drugs, and some are inherited. So first we have ulcerative colitis. So remember, colitis is the colon, so this is inflamed colon. It only affects the colon. It's going to start at the anus and work its way all around up the colon. Crohn's disease is a little different because it can happen anywhere on the GI tract. So that includes the mouth all the way down to the anus. And it's not continuous, which means it can have these jumps. So you have like inflammation and then healthy, inflammation and then healthy. All right, so here is Crohn's disease. Again, mouth to anus. Lesions skip normal tissue between areas of inflammation. This affects all layers of the bowel wall. Oftentimes, the mucosa of the GI tract will look like cobblestone as a result of deep ulcerations. The most common complication of Crohn's disease is stricture, which can lead to bowel obstruction. So that recurrent inflammation can also lead to fistulas and leaks. Okay. Signs and symptoms: diarrhea. Diarrhea. If you got Crohn's disease, your biggest symptom is diarrhea. So you can experience weight loss, abdominal pain, steatorrhea, which is fatty-looking stools, fever, fatigue, and some rectal bleeding. So with Crohn's disease, you can have some rectal bleeding, just not as significant as colitis, okay? But yes, you can have some rectal bleeding. Okay, let's talk about ulcerative colitis. So this starts in the anus, okay? Moves its way through the rectum and just keeps on going up the colon. This one affects the innermost mucosal layer of the colon. Patients are going to have diarrhea. They're not going to be able to absorb the nutrients wherever that inflammation is. So that's going to lead to some nutrient deficiencies and protein loss in the stool. Signs and symptoms. This one's going to have diarrhea, but it's going to be bloody. Okay, versus Crohn's disease, where you could maybe have a little blood, this one's going to be bloody. So they can actually have significant blood loss where it lowers their hemoglobin and hematocrit. Weight loss, abdominal pain, fever, and fatigue. Complications from both Crohn's and ulcerative colitis: they can have hemorrhaging, strictures, perforation, abscesses, fistulas, C. diff, colonic dilation, which is megacolon. Patients with either of these are at higher risk for colon cancer and other systemic complications. Diagnostic studies: we're going to get a good H&P. We're going to do lots of labs listed here. We can test the stool. We can do some imaging studies, colonoscopy. When patients have an exacerbation of both Crohn's or ulcerative colitis, we want to rest the bowel. These patients should be NPO. Okay, rest the bowel. Give the bowel a chance to relax a bit. And then we do, once the episode has passed, then we want to make sure we can focus on their nutrition, make sure the infection's gone, inflammation, and improve their quality of life and help them reduce those exacerbations. All right, so goals of medication. We want them to go into remission and we want them to stay there. So the medication depends on the severity and location of inflammation. So there's two approaches, step up and step down, which just depends on the patient and the provider. So this one on the left is the step up approach, which means the patient is going to start with these 5 aminosalicylates, 5 ASA drugs, and antibiotics. And then they're going to work their way up this pyramid here until finally they'll have surgery. The second approach is top down. That means they're going to have surgery first, and then they're going to do possible biologic therapy, immunosuppressant steroids, and antibiotics, and so on. So these 5 aminosalicylates, we call them 5 ASAs. These are some examples of them here. And they work to control inflammation. So these are very effective with ulcerative colitis, but not so much for Crohn's. So if you have a patient that has a mild case of Crohn's, then they probably won't be on these 5 ASA type drugs. So the way these work is there are some that are given orally, PO, through enema, through a foam, or via suppository. So it really depends on what you're trying to treat. So if you take an oral medication, this is the part of the colon that will reach, which will benefit from it. Okay, if you give an enema, this is what will benefit, foam here, and so on. Okay, a little more on drug therapy. So we can give corticosteroids, helps with inflammation. This is given short term because long term side effects can happen, immunosuppressants. So we should all be familiar with all of these. And this is just more information for you, so read through that. Okay, so ulcerative colitis surgery is an option. It really just depends on the patient. If they have their whole colon that's affected, then they will definitely benefit from having their colon removed, and it is curative. So you can read up on patients' stories that have had really severe ulcerative colitis and they beg to get an ostomy because the bleeding and the cramping and the diarrhea and the pain is just so cumbersome to their life that having an ostomy is like a new life. So there's 2 types of surgeries, total proctocolectomy and then a total proctocolectomy with permanent ileostomy. Okay, you can see here in the picture. Again, this just depends on the patient. And remember, surgery is curative. For Crohn's disease, surgery is not normally done. It's only done for complications. So, and that's also because it's from the GI tract all the way down. So patients can have issues all throughout the GI tract. But the most common surgery that's done is related to strictures, where the intestine has narrowed so much that it's almost going to obstruct stool. So there's 2 approaches here. They can either cut off the bad part and then do an anastomosis, or they can kind of like you can see in this picture, here's the stricture, so they make a little incision so it's wider, and so on. All right, for IBD nutrition. So usually they are nutritionally deficient, okay, because they're not hungry, they don't want to eat, maybe they have some bleeding, so they're gonna be anemic, and they just can't absorb all of those nutrients. That inflammation, recurrent inflammation, changes the mucosa of the intestine, and it just doesn't do its job as well, or at all. Medications that are used to treat IBD can also cause nutritional problems, and when a patient is having an acute exacerbation, and that goes for Crohn's or ulcerative colitis, they may not be able to tolerate a regular diet. So liquid enteral feedings are preferred. High calories, high nutrients, lactose-free, easily absorbed. We just want to make it easy for the digestive system to work. And then once the inflammation has gone down, regular foods are introduced gradually. All right, so generally speaking, nursing care management in the acute care setting, we want to make sure they have hemodynamic stability, pain control, fluid and electrolyte balance. Okay, so all of these things we already know. Here, post-operative care. So these patients might end up with an ostomy, so that's going to be another layer of education for them. And let's see, disease management, pornographs. Okay, so you can read through all of these things. Okay, and here's our gerontologic considerations on IBD. So the diagnosis can be more challenging for the older patient. Their complaints might be a little different. Medication and surgery, they can be more at risk for complications, longer hospitalizations, and death. They also have a higher risk for infection and cancer as they get older. More common will be anemia, malnutrition, and volume depletion in them, and getting to the bathroom may be more difficult. So definitely high fall risk for these patients and at risk for impaired skin integrity. Moving on to bowel obstruction. So this is inadequate blood flow to the bowel, and as you see in the picture, this is what it looks like when blood is not getting where it should be. It dies. So this ischemia results in necrosis and perforation, so it can rupture and then the contents will spill out, so that's what we're trying to avoid. Okay, these are categorized by partial and complete. So partial means some movement can still happen. Complete is total occlusion, so those patients will likely need surgery. Simple means everything is still flowing okay blood-wise. Strangulated means it's being strangled and there's no blood supply. That is bad. Okay, causes of bowel obstruction. We have mechanical. So something physical is happening, like surgical adhesions. We learned about adhesions, hernia, cancer, strictures from Crohn's disease. So there's actually something physical there. Non-mechanical refers to reduced or absent peristalsis. So for some reason, the bowels just aren't moving things. So things get backed up and they just kind of sit there. This includes paralytic ileus. Okay, so paralytic ileus can be a result of a major trauma, abdominal surgery, peritonitis, electrolyte imbalances can cause paralytic ileus. So a lot of things can cause the GI system just to kind of stop. Then we have pseudo obstruction. So this is a GI motility disorder, again, very similar to non-mechanical. This includes burns, trauma, cancer, so they kind of overlap. Okay, and then vascular obstruction. So this is when an emboli or thrombi alter the blood supply. So with these, you don't need to know, remember, they just know it exists, and bowel obstructions are bad. Okay, here's some pictures of bowel obstruction straight from your textbook. Review those. Okay, hallmark sign and symptoms of bowel obstruction. Obstruction is abdominal pain, nausea, vomiting, distension if it's in the large bowel, aka colon, and constipation. So we want to get a good history and physical. We want to know when did it happen, how long has it been going on, when was their last bowel movement, what kind of bowel movement did it look like. Oftentimes when there's a bowel obstruction, they get constipated and then they take laxatives, and then they take the laxative and they start having diarrhea and they think they're okay. But in reality, they have a bowel obstruction, and the liquid that they see as diarrhea is actually the liquid trying to move around the bowel obstruction. So it's important to have to ask all of these questions. Imaging, we can do a KUB, which is an abdominal x-ray, CT scan, enemas, colonoscopy. We're going to do lots of blood work here to see if we can get clues on what's going on. And then the treatment is just going to depend on the cause. If the patient has a perforation or strangulation, that's automatic surgery. They may need to cut out a piece of the bowel, which means they are going to have an anastomosis, which means you're going to look out for those signs and symptoms post-operatively. So initial treatment for bowel obstruction is obviously going to be NPL. You don't want to give them food if it can't go through the bowel. IV fluids, antiemetics, NG tube, possibly obtain cultures, IV antibiotics if necessary, and they may need parenteral nutrition. If this is related to cancer, we want to regain patency, so we want to open up the bowel. This can include stents. They need IV fluids and corticosteroids with antiemetics. And this is because with cancer, we have to take into consideration the patient's goals and their specific needs. So that's why it's a little, stents might be an option for those patients. Okay, again, this is a lot of repetition here. So fluid and electrolytes, pain management, positioning, early amputation. Now, early ambulation will help to reduce gas and discomfort post-operatively. NG tube, good oral care, okay, all of these kind of similar things that we've been talking about. If they have like a partial obstruction and we are watching and waiting to see if this resolves on its own, we want to make sure we're assessing them frequently so that it doesn't turn into a total obstruction. We're going to monitor the vital signs, changes in bowel sounds, decreased urine output, increased distension, and pain. So say the patient has a partial bowel obstruction and you're the nurse and you're just kind of watching and waiting, and all of a sudden you see they haven't had much urine output, their abdomen is becoming distended, and they have increased pain. You can no longer really hear their bowel sounds. That is an indication that it may be turning into a complete bowel obstruction. So that is reportable. Now on to polyps of the large intestine, aka colon. So colon polyps come from the mucosal surface and project into lumen. So if you see here in the picture, some are pedunculated. This is a pedunculated polyp, and this is a sessile polyp. Okay, and then they become this as they get bigger and bigger. So this one, they'll eventually have a little stalk here, where this one is just kind of flatter, no defined stalk. So the incidence of this increases with age, especially in the proximal colon. So the distal colon is near the rectum, proximal is near the small intestine. These are usually asymptomatic, but when they become symptomatic, you may have rectal or occult bleeding. Okay, here we have types of polyps. We have hyperplastic and adenomatous. So the first hyperplastic is non-cancerous. They're usually less than 5 millimeters in size. They don't have symptoms, and they are benign. And other benign hyperplastic type of polyps would be inflammatory, lipomas, and juvenile. Adenomatous, aka neoplastic. There are 3 types. That means that they are high risk for cancer. If you remove them, it decreases the patient's risk for cancer. But remember, all polyps should be removed. There is a genetic link to certain types of polyps. We have this familial adenomatous polyposis, FAP. This is the one where patients that have a family history of this should be screened at puberty and annually after the age of 16. So these patients may develop hundreds to thousands of polyps that will 100% become cancerous by the age of 40. So this requires removal of the colon and the rectum by age of 25. Okay, so this is pretty serious. And then in addition, patients who have this condition are at risk for other types of cancers, so they need lifelong follow-up. Okay, so management and diagnostics of polyps. So these are easily seen in colonoscopies, sigmoidoscopies, barium enema, where you're given that barium via enema and then they light up on the screen here as shown here. Again, all polyps are abnormal and require removal. So patients who have a routine colonoscopy, the doctor will just automatically remove as many polyps as they can. If the patient has a lot of polyps and they're unable to get them, or maybe if they're really, really big, then they may have to schedule another colonoscopy, or they may need to do it like in a hospital, because these are usually done in a outpatient surgery center. So post-procedure, we want to monitor for bleeding or perforation, rectal bleeding, fever, severe abdominal pain, and distension. Moving on to colorectal cancer, or CRC for short. So CRC is more common in men than women, and the risk for it increases with age. So 90% of new diagnoses of this are in people older than 50. There's no single risk factor for most of patients who are diagnosed with CRC, but people with first-degree relatives that have it and people with IBD, irritable bowel disease, are at higher risk for CRC. Symptoms. So symptoms for this often don't appear until the disease is in its advanced stages. Colorectal cancer is very serious. That's why if you already have a familial tendency for it, you should get colonoscopies at a younger age. So common signs and symptoms would be iron deficiency, anemia, rectal bleeding, abdominal pain, change in bowel habits. That can mean constipation or diarrhea, frequency, any combination of those. Early, again, non-specific, usually asymptomatic, but could include fatigue and weight loss. All right, so interestingly, this part of the colon is very common for women to develop cancer there, and this part of the colon is men. That's not a rule, just generally speaking, which is kind of interesting. You can have different clinical manifestations, depends on where the cancer is, so you can kind of read through that. You won't be tested on specific points like what are the signs and symptoms if the cancer is in the ascending colon. Just know that these are all clues to, a GI problem. Metastasis. So metastasis is very common in colorectal cancer, and that is because the blood that drains from the colon and the small intestine goes directly to the liver. So it's just a matter of time before those cells break off and travel to the liver and metastasize. Diagnostics for this one, family and individual history is very important. So you really want to get a good history on the patient. Really important. That's going to be your number one. Colonoscopy is considered the gold standard to prevent and detect this type of cancer. So a normal person with average risk should get a colonoscopy every 10 years, beginning at age 45. If you are at higher risk, like for example, you have a family member that has already had colon cancer, then it should be done earlier and more frequent. There's other types of screenings that can be done for polyps. Again, you're usually going to see a colonoscopy, but that includes the flexible sigmoidoscopy, a double contrast barium, and a CT colonography. All right, so annual screening primarily for cancer. They have specialized tests, includes high sensitivity fecal occult blood test, fecal immunochemical test, FIT. So this is very, not everybody is going to get these things. It's usually because they have that family history or they have other signs and symptoms that they're high risk for. So we can do stool DNA every 3 years. Tissue, of course, to a biopsy to confirm the diagnosis. We want to do blood tests, CEA, which is carcinoma embryonic antigen testing. With any cancer, I'll repeat it again, we want to cut it out. We want to get it out of the body. That is the cure. So that is going to be based on how extensive the cancer is, where has it spread, what other organs has it invaded. So goals would be to completely resect the tumor if possible. We want to go through the abdomen. We want to make sure we remove all the lymph nodes that drain to the area, because remember, our lymphatic system, highly chances of metastasis if it is affected. And we also want to restore the bowel continuity. Remember, we're not only removing whatever's infected of the bowel, but the patient still needs to have some kind of functioning GI system. And then, of course, we want to prevent other surgical complications. So polypectomy during colonoscopy is used to resect CRC in situ. So if they find a polyp that is cancerous, then they can remove it on the spot, hopefully, and before it becomes more severe. This is going to be considered successful when they have resected the polyp with a clear margin. I just kind of picture this like an ice cream scoop, making sure they get enough good tissue out to ensure that there's no cancer is left behind. Okay, so again, decision for surgery considers the staging, the location, and the ability to restore bowel function and continence. Okay, we are familiar with chemo and radiation and targeted therapy, so this is also an option for CRC. Nursing management, we want to educate on, all of those things: healthy weight, exercise, don't drink, don't smoke, eat a good, healthy, balanced diet that includes fruits, vegetables, and grains. Health promotion, regular CRC screening starting at age 45. Identify those high-risk patients so that we can start screening early for them. And we want to, part of our responsibility is prepping them for colonoscopy. So acute care, these patients are going to have a bowel resection and possible ostomy surgery. So this is very similar to any abdominal surgery post-operatively. If they did remove a lot of structures and a lot of tissue, then they may have a drain, they may have a big incision, and they may have that ostomy. So that all requires teaching to both the patient and their family. Once they are discharged, they're going to need support, psychological support, because they had cancer, major cancer, they had a major surgery, and they probably now have an ostomy. So we want to make sure that we take all of that into consideration. We make sure they follow up, get them a wound care nurse consult, and also they're going to need ongoing education on that ostomy. Okay, so general bowel resection and ostomy surgery. So surgical resection, reasons why we do bowel surgery, reasons why we cut pieces of the bowel out. Okay, we just talked about cancer. That's one. We do this to repair a perforation, which is a hole, a fistula, or just other type of injury that may have cut the bowel. If there's an obstruction or a stricture, we can resect the bowel. If there's an abscess or some other kind of inflammatory disease like colitis, or if there's some source of bleeding that we need to remove. Those are all reasons that patients may have surgical resection of the bowel. There are lots of different types of bowel surgery, and it's all based on what the patient needs, what is going on with the patient. And it's always aimed to maintain bowel function. We want to make sure that they're able to have normal bowel function and hopefully fecal continence, which isn't always an option, but that is the goal, so that they can be continent of stool. These are all the different types of bowel surgeries. Again, I mentioned you don't need to memorize them all, but just be familiar with what they're talking about. So if you see the proctocolectomy, then you should know that's a bowel surgery. Or if you hear hemicolectomy or low anterior resection, then you should know that those are bowel surgeries. Okay, this is a picture of the different types of ostomies. So the name refers to where the ostomy is located. So if a patient had their entire colon removed, the ostomy that would be protruding would be the small intestine. So that would be called an ileostomy. Okay, anything with the word colonoscopy means that they still have some colon, that piece that's protruding. The stoma is part of the colon. Okay, so if you ever have a patient with ileostomy, that means they have no colon, and that is the small intestine that you see protruding. So I'm not going to go into too much detail right now. Please read through this. For this portion, the PowerPoint slides are enough to study. You don't need to read the textbook on this one. So we have the traditional permanent ostomy. Please read through that. We have a double barrel stoma. That. Sigmoid colostomy. Loop colostomy. All right, post-operative care. What is your role? Closed wound, we need to monitor incision and sutures. Obviously, if it's an open wound, they're going to have dressing changes. We're going to monitor all those things for signs and symptoms of infection, the drainage, the labs, the fever. We always know that there's going to be some degree of inflammatory response, but we want to make sure we know the difference between inflammation and infection. We're going to assess for complications. We are familiar with delayed wound healing, hemorrhaging, bleeding, fistulas, and infection. So ostomy characteristics. A fresh new ostomy out of surgery is going to be pink, red. It's going to be a little bit swollen, and there will be a small amount of blood present. And usually you can see some sutures in place also. So post-operative care. So you have a new colostomy. We want to make sure it's working. So you need to document the volume, color, and consistency of the drainage. Gas is common for the first 2 weeks, so that is not reportable and it's temporary. For an ileostomy, it's going to take a little while longer for that one to start functioning, at least 1 to 2 days, so 24 to 48 hours. Once peristalsis returns, they're going to have output about 1,500 to 1,800 milliliters a day. That's a lot. So because they're losing all this fluid, because if you think about it, our colon is what absorbs all of that liquid to produce formed stool. So these patients don't have a colon, so they're going to have liquid stool. Eventually, you know, the body's pretty smart and it's going to notice like, hey, we don't have a colon and we're losing all this fluid. So eventually the bowel will adapt and increase absorption in the small intestine, and it will thicken and then the volume will decrease. But during this time where they have, you know, a lot of liquid output, we have to monitor fluid and electrolyte imbalance. Okay, so if the patient has Crohn's disease and they had surgery, they're going to be at higher risk for obstruction for about 1 month postoperatively. If they had that IPAA surgery, which is an ileal pouch anal anastomosis, then you can expect 4 to 6 stools a day. Eventually, over a few months, the anal sphincter will control defecation, which is nice because they're going to keep their continence. And then the anal canal may have transient incontinence of mucus, okay, something they can't control. We should advise them to do Kegel exercises, make sure they maintain perianal care, and they may experience some phantom rectal pain. All right, so this is self-study colostomy care. It should be, you know, somewhat review for you. So read through this again. Just reading the PowerPoint will be enough. Okay, more colostomy care. Lots of different types of pouches. Ileostomy care, just read through this. Okay, adapting to an ostomy, providing support. Sexual function, providing education. Okay, diverticulosis and diverticulitis. So we already know what a diverticula is. That is that little pouch that it finds its way through like a weak point in the mucosa in the intestinal wall. So it kind of like pokes out, makes these pouches. You can see here, there can be a lot of them. This is more common in the older adult. All right, so by definition, diverticulosis are multiple non-inflamed diverticula. Diverticulitis is one or more inflamed diverticula. Okay, so non-inflamed and inflamed. So complications from this can lead to perforation, abscess, fistula, and bleeding. Genetic and environmental factors. One of the main factors is constipation and lack of dietary fiber. So these patients should be educated on that. Other factors include obesity, sedentary lifestyle, smoking, lots of alcohol, and NSAID use. All of those things can lead to diverticulitis. So diverticulosis, now this is the one that there's no inflammation, is usually asymptomatic. When symptoms start to arise, they can have abdominal pain, bloating, flatulence, changes in bowel habits. Again, whenever you see changes in bowel habits, it could mean both constipation or diarrhea. However, it can actually cause bleeding and lead to diverticulitis eventually. All right, then we have diverticulitis. This manifests as pain, usually in the left lower quadrant, distension. You can have decreased or absent bowel sounds, nausea, vomiting, and some systemic symptoms of infection. So that's going to include maybe temperature and high heart rate, high respiratory rate. Older adults may not have a fever. They may have a normal white blood cell count, but they may have abdominal tenderness. Complications can be erosion of the bowel wall and perforation, abscess, peritonitis, and bleeding. So very similar to complications of any intestinal problem. With this one, we are going to do sigmoidoscopy or colonoscopy to take a look, see what's going on in there. We're going to do lots of blood tests, barium enema, possible blood cultures, x-rays. And you can see here, this looks like a barium enema. You can see all the diverticula there. All right, so how do we prevent this? So prevention, okay, so this is when they don't have diverticulitis yet, okay? I'm going to emphasize that. They should be on a high fiber diet and low fat, low red meat. Okay, that says red mat, but that's meat. And they should maintain daily physical activity. Again, to prevent this, they should be on high fiber diet. Now, when they have acute diverticulitis, okay, so now it's inflamed, they need to rest the bowel to reduce inflammation. So they might be NPO, they might only be on clear liquids, bed rest, and pain meds. Now, those patients should have low fiber. Okay, I'm just throwing that out there because I believe there's a question in ATI that kind of gets a little specific, but to prevent, it's high fiber. But during this acute diverticulitis, it's going to be low fiber. All right, so severe symptoms include if they're having a systemic infection and they have lots of other comorbidities, then they may need hospitalization. So we're going to do NPO, NG tube, bed rest, IV fluids, and antibiotics. We're going to look out for these signs and symptoms of complications. If this keeps happening again, or they keep having complications, then they may remove like the part of the colon that is causing problems. That might also lead to a temporary colostomy. Okay, so we want to educate these patients, let them know what's going on. They should be on a high fiber diet, lots of fluids, at least 2 liters a day, and avoid intra-abdominal pressure. And again, like I mentioned, 1 through 4 here, high fiber foods, remember those. Okay, a little bit about fistulas. So a fistula is an abnormal tract between 2 hollow organs or a hollow organ and the skin. So this is the rectum. You can see that there is a little tract here, a little tube, a little pathway that leads from there to the skin surface. So they can be simple, they can be complex, they can start to ooze, they can cause infection, which is going to lead to fever, pain. We want to identify it. We want to make sure they have adequate fluid. We check their electrolytes, control the infection if it's infected, protect the skin. So we want to get a wound nurse consult. We want to monitor the drainage if it is draining. Get a dietitian on board. These patients should have a high calorie, high protein for wound healing. Hernias. This is protrusion of intestine through a weak area of the abdominal wall. Okay, it just kind of pops through. So if it is reducible, you can just kind of push it back in and they can sew that opening in the wall, that weakened area in the wall shut. If it is irreducible or incarcerated, that means that this is trapped on the outside and it cannot be put in. So those patients will likely need surgery, especially if it is strangulated, like this picture. These are some different types of hernia. It can really happen anywhere where you have intestine. Okay, so these patients will probably have pain. You can probably see it from the outside, a little bulge. If the intestine is already strangulated, they're going to have severe pain, possible vomiting, cramping, pain, and distension. So diagnosing this, again, we're going to get a good H&P, going to do imaging, and the treatment really depends, again, like what's going on with it. They can do surgical repair, they can put a mesh in. If it's strangulated, for sure they're going to have surgery, and so on. So postoperatively, one thing that's a little different with this one is scrotal edema. So these hernia repairs can cause that in men. So we would ice and elevate the scrotum. We encourage deep breathing, splinting, which is what this guy here is doing with a pillow. Coughing or sneezing with an open mouth will encourage, it decreases intra-abdominal pressure. Try it out. And then no heavy lifting. This is on malabsorption syndrome. This is an umbrella kind of thing. Syndrome, whenever you see the word syndrome, that means it's an umbrella. It includes just like a cluster of signs and symptoms. So this is when you aren't absorbing fats, carbs, proteins, minerals, and vitamins at some degrees. One or the other, all of them. A lot of times the most common cause is going to be lactose intolerance. Other common causes would be IBD, celiac disease, tropical sprue. This is a chronic disease of diarrhea, and cystic fibrosis. Common signs are weight loss, diarrhea, steatorrhea, which is fatty looking stools. So diagnostic wise, we are going to test that stool. We are going to test for celiac disease. We're going to do imaging and labs. And then whatever the cause is, that's what's going to be the treatment. All right, on to celiac disease. This is autoimmune. Okay, you see this picture. This is what the normal intestinal villi should look. These are these little villi that kind of wave around and collect nutrients coming through the intestine. Well, with celiac disease, all of these little villi atrophy. So there is reduced surface area. There's not enough surface area to absorb the nutrients coming in. So this is triggered by gluten. So celiac disease, think of gluten. Gluten is bad. And gluten is found in wheat, barley, and rye. So this disease is also is commonly combined with other autoimmune disorders. So people who have rheumatoid arthritis, type 1 diabetes, thyroid disease, for example, are often going to be tested for celiac disease on a regular basis because that's something that can develop over time. So 3 factors that cause this: genetics, okay, eating that gluten, and an immune-mediated response. Signs and symptoms: foul-smelling diarrhea, abdominal pain, flatulence, abdominal distension, and malnutrition. We can screen, meaning we can test the blood on patients who are high risk, like patients who already have autoimmune diseases. We want a history and physical, of course. We want to check for nutritional deficiencies. We want to check the cells of the small intestine, so that might be a biopsy. And then genotyping, again, using that same tissue biopsy to kind of look even further into the genetic structure. The treatment is easy: gluten-free diet. Okay, we want to make sure we monitor their nutrition, including anemia and bone density, because if they're nutrient deficient, it can affect all those things. For sure, these patients at diagnosis need some type of dietary consult, because this is a lifelong change, lifestyle adjustment. So they're going to need to be taught to read food and medication labels. They need some support and resources on where to buy gluten-free products, and then, you know, traveling and eating at restaurants, they should be able to recognize what has gluten and what does not. So these are common sources of gluten. So anything with wheat in it. Almost done here. So lactase deficiency. So lactase is an enzyme. So either the person is deficient or they don't have it at all. So lactase breaks down lactose. Okay, so lactose is in milk products. So if the person is lacking that enzyme, that lactose is going to start to ferment and grow bacteria, which causes all of our signs and symptoms for those patients. So people who are prone to this, it can be inherited, if you have Asian or African ancestry, or if you were premature at birth, so you're more likely to have a lactase deficiency. Symptoms include bloating, flatulence, cramping, abdominal pain, diarrhea, and it usually happens pretty quickly after eating something with lactose in it. So we can do a lactose tolerance test, lactase hydrogen breath test, or we can do genetic testing. And the treatment is stay away from the lactose, so milk, dairy products. And we want to keep an eye on the calcium because of that reason. There are lots of different things on the market now that don't have lactose, so patients can be educated on that. Short bowel syndrome. So this is when there is a short bowel. This is due to intestinal mucosa damage, congenital defects, surgery to remove 70 to 75% of that small intestine. So you can see here in the picture, okay, for some reason, whatever reason, they don't have all of their small intestine. This is going to lead to dehydration, weight loss, diarrhea, malnutrition, vitamin deficiencies, as everything you would expect when you don't have, your full small intestine. So we just want to make sure that they maintain their fluid and electrolyte balance, make sure they're getting enough nutrition, and we want to control that diarrhea. We need a dietitian. They may benefit from parenteral or tube feedings. We want to give medications to kind of slow down that fecal output. They may need a special individualized diet. They could also get an intestinal implant. All right, moving on to hemorrhoids. Hemorrhoids are dilated hemorrhoidal veins. So they're just veins, similar to varicose veins and esophageal varices that we talked about. These veins are engorged with blood, and the cause is increased anal pressure, and weakened connective tissue results in downward displacement. So what does that mean? So this is the rectum here. Okay, this is the anus. So there's increased pressure in here. Okay, whatever's causing the pressure, and these mucosa sides become weak, and this downward pressure kind of pulls out these engorged veins. So risk factors: pregnancy, constipation, straining with bowel movements, diarrhea, heavy lifting, prolonged standing, sitting, obesity, and ascites can put you at risk for hemorrhoids. If the hemorrhoids are internal, they are more likely to bleed with bowel movements. There'll be pain, and they have a possibility of prolapsing, which means the hemorrhoid will kind of get pushed outside of the anus. The external ones can be a different color than the skin, maybe reddish blue in color. They may itch, they could burn, they might be a little edematous. Thrombosis is almost like if it was being strangulated. These are bluish purple in color, definitely palpable. They'll be painful, inflamed, and definitely bleed with bowel movements. Diagnosis: we're gonna do an internal inspection, a digital exam, sigmoidoscopy, endoscopy. You can check your textbook for that. Treatment: we are essentially trying to decrease pressure and straining. So high fiber diet, increase fluids. There's lots of ointments, creams, suppositories, all kinds of stuff you can buy over the counter to help with inflammation and pain. They can also prescribe maybe like a hydrocortisone suppository that can be soothing. If the patient has external hemorrhoids, they are usually benign and they won't do anything to them unless they're causing some kind of issue. So internal, because those are more at risk for bleeding, those, if they get big, they can ligate them or use some type of coagulation tool, sclerotherapy, laser treatment. A hemorrhoidectomy is a little surgery where they actually cut them off, okay, and that's done if they are prolapsing or if they have thrombosed. So if they do that, then you're going to have a wound that you'll have to tend to. Again, treatments, we went over that. Conservative, again, educate on constipation, over-the-counter meds, what to report and when to seek medical care. They would benefit from a sitz bath, okay. Post-op, if they have a hemorrhoidectomy, they're going to have pain, and pain in that area may prevent them from having a bowel movement conscientiously. So we want to make sure their pain is controlled, so give them pain medication. They're going to have a wound, which may include packing, and dressing changes. So if they go home, they may need help with that or education on that. Promote defecation, so high fiber, fluids, possible stool softener. And then we're going to educate on all our usual complications like bleeding, signs and symptoms of infection, and of course avoiding constipation. Okay, this is self-study, so again, reading the PowerPoint will be enough for these, for anal fissures, anal rectal abscess, anal fistula, we kind of talked a little bit about that one, anal cancer, pilonidal sinus. So you can read up on that, and that concludes this chapter.